Many people believe COVID ends once you test negative, but research in 2025 reveals a shocking truth. Long COVID is leaving a hidden scar on the heart, increasing risks of heart attack, failure, and arrhythmias even months after infection. Overview and evidence by 2025, the evidence linking long COVID, also called post-acute sequelae of SARS-CoV, to infection, or PSC, to cardiovascular damage has become far stronger. Recent systematic reviews and meta-analyses have shown that individuals who recover from COVID-19 face significantly increased risks of heart complications, such as heart attack, heart failure, arrhythmias, and vascular disorders, extending for months or even years after the initial infection. This risk is not confined to patients who are hospitalized with severe COVID. Even those with mild or moderate infections report late-onset cardiac symptoms and measurable abnormalities. What is striking is that the increased burden of cardiovascular disease in post-COVID individuals is evident across multiple age groups and ethnicities, though it appears more pronounced in people with pre-existing conditions such as hypertension, diabetes, or obesity. Researchers now view long COVID not simply as a set of lingering fatigue and brain fog symptoms, but as a multi-system disorder with a particularly dangerous impact on the heart and blood vessels. Clinical observations and population data indicate that chest pain, palpitations, breathlessness, and exercise intolerance remain among the most common complaints in long COVID clinics worldwide. In public health terms, this suggests a looming wave of long-term heart disease that could place substantial strain on healthcare systems globally. As a result, experts now recommend early cardiovascular screening in COVID survivors who present with persistent symptoms, regardless of their initial disease severity. The overall scientific consensus in 2025 is that the cardiac consequences of long COVID are both real and clinically significant, requiring urgent attention from cardiologists, primary care physicians, and policymakers alike. How can a virus that starts in the lungs silently damage the heart for years? Scientists now uncover multiple pathways: chronic inflammation, viral persistence, microclots, autoimmunity, and nerve dysfunction, together creating a perfect storm of cardiovascular harm in long COVID patients. Biological mechanisms. Understanding how long COVID damages the heart has been a major focus of recent research, and multiple overlapping biological mechanisms have been identified. First, chronic inflammation plays a central role. COVID-19 is known to trigger a powerful immune response, and in some people, this persists long after the virus is cleared. Persistent immune activation can inflame the endothelium, the inner lining of blood vessels, and the myocardium, heart muscle, leading to myocarditis or vascular dysfunction. Second, the theory of viral persistence has gained traction. Fragments of SARS-CoV-2 RNA or proteins may remain hidden in tissues, provoking ongoing immune responses that damage the heart over time. Third, long COVID has been strongly associated with microthrombi, tiny blood clots that impair blood flow and strain the heart. These microclots are difficult to detect, but may explain why some patients experience chest pain or reduced exercise tolerance despite normal routine tests. Autoimmune mechanisms are another possibility. In certain patients, the infection appears to have triggered autoantibodies that mistakenly attack cardiac or vascular tissues. Finally, dysregulation of the autonomic nervous system, known as dysautonomia, can disrupt heart rhythm and blood pressure control, causing palpitations, dizziness, and orthostatic intolerance. Collectively, these pathways, chronic inflammation, endothelial dysfunction, microthrombosis, viral reservoirs, autoimmunity, and autonomic imbalance, form a complex biological explanation for why long COVID has such wide-ranging and persistent effects on the heart. What makes the challenge greater is that different patients may experience different dominant mechanisms, which complicates both diagnosis and treatment strategies. Standard heart tests often miss the hidden dangers of long COVID. That's why cutting-edge imaging like cardiac MRI has become essential, revealing damage invisible to routine scans and helping doctors catch early warning signs before they turn into major heart disease. Diagnostic tools and imaging when it comes to detecting heart damage in long COVID patients cardiac MRI, CMR, has emerged as a gold standard. Advanced CMR techniques can reveal subtle changes in myocardial tissue, such as late gadolinium enhancement, LG, fibrosis, or signs of lingering inflammation, even when echocardiograms appear normal. Studies published in 2024 and 2025 describe long COVID patients with persistent chest pain or fatigue who showed abnormalities on CMR despite normal troponin levels and normal ECGs. This highlights the unique sensitivity of MRI in uncovering hidden cardiac injury. However, interpreting these findings is not always straightforward. Some patients with minor MRI changes may never develop serious clinical symptoms, making it difficult to know which abnormalities require aggressive follow-up. For this reason, cardiologists emphasize using a layered diagnostic approach. Patients with ongoing chest discomfort, shortness of breath, or arrhythmias are typically assessed first with ECG, blood biomarkers, such as troponin and BNP, and echocardiography. If suspicion remains high, advanced imaging with CMR or even CT angiography is considered. Ambulatory heart rhythm monitoring, such as Holter devices, is also valuable for patients reporting palpitations or dizziness. Diagnostic workups are now being guided by risk stratification. Younger, otherwise healthy patients with mild symptoms may only require reassurance and lifestyle advice, while older patients or those with risk factors undergo more thorough cardiac investigations. The ultimate goal is not just to identify structural or functional abnormalities, but also to determine which patients are at genuine risk of future heart failure, arrhythmias, or sudden cardiac events. Long COVID doesn't strike the heart equally. Women may face more vascular stiffness, men more myocarditis, and even the young can develop new hypertension. Vaccination lowers risks, but millions worldwide remain vulnerable, reshaping the global heart disease landscape for decades ahead. Population risks and demographics. Long COVID's impact on the cardiovascular system is not evenly distributed across the population. By 2025, large-scale cohort studies have confirmed that patients with pre-existing metabolic or cardiovascular risk factors, such as obesity, diabetes, hypertension, and prior heart disease, are at highest risk of post-COVID cardiac complications. Interestingly, however, new data show that even individuals with no prior risk factors can develop new-onset hypertension, arterial stiffness, or unexplained arrhythmias after infection. Some studies have noted gender-specific differences. Women, for instance, appear more prone to developing vascular stiffness or autonomic dysfunction months after COVID-19, while men may show higher rates of myocarditis or arrhythmias. Age also plays a role. Older adults are more likely to develop structural heart disease post-COVID, while younger patients more often report palpitations, tachycardia, or postural orthostatic tachycardia syndrome, POTS. Vaccination status remains a major protective factor. Multiple studies indicate that individuals who were vaccinated before infection tend to experience less severe, long COVID symptoms and show lower rates of cardiovascular abnormalities on follow-up. At the public health level, these findings suggest that long COVID could significantly increase the long-term prevalence of heart disease, potentially reversing years of progress in cardiovascular prevention if not properly addressed. This highlights the urgent need for screening programs, patient education, and lifestyle interventions tailored to COVID survivors. Governments and healthcare systems must now plan not only for acute COVID waves, but also for the long tail of chronic heart disease that may follow in their wake. What can be done if long COVID is damaging the heart? Doctors now focus on early detection, standard heart therapies, and rehab, while researchers race to develop new treatments. The future depends on prevention, vigilance, and scientific breakthroughs still to come. Clinical management and future directions. The clinical implications of these findings are profound. By 2025, cardiologists and international medical societies emphasize the need for early recognition and careful management of heart complications in long COVID patients. Patients presenting with classic myocarditis symptoms, chest pain, arrhythmias, or signs of heart failure are recommended to undergo cardiac MRI, ECG, and troponin testing promptly. For many, Management remains symptom-driven. Standard heart failure therapies, rhythm control medications, and anticoagulants are prescribed where appropriate. Gradual rehabilitation and exercise pacing programs are being adopted in long COVID clinics to help patients safely regain stamina without overloading the heart. Still, there is currently no specific therapy that directly targets the underlying cause of long COVID heart damage. This makes research into mechanism-based treatments, such as anti-inflammatory drugs, antiviral therapies to clear viral reservoirs, or targeted anticoagulation strategies, a top global priority. Randomized controlled trials and large cohort studies are underway to determine which interventions can truly modify outcomes. Until then, best practice involves personalized care, close monitoring, and risk-based screening. Ultimately, the long COVID crisis is reshaping how clinicians think about viral infections and their long-term effects on the heart. What began as a respiratory pandemic has revealed itself as a multi-system condition with lasting cardiovascular consequences. The next phase of research and clinical care must focus on prevention, early detection, and targeted interventions to reduce the long-term burden of heart disease in COVID survivors.